So we just had some great conversation, and we're really hearing about like the different policy levers and payer levers sort of at the system level that can drive change. And I was wondering if you might tell everyone the story of how a single measure helped drive change in terms of creating an opportunity to expand collaborative care across all of Northwestern.
I would love to. So my name is Katie Doyle. I'm from Northwestern Medicine in Chicago. I'm a nurse first and always, important to share. I've been there for 20 years. And to Leanne's question, we probably started looking at this about 8 years ago. And it really did start with a measurement. Cindy Barnard was leading our quality team, and we wanted to understand what we were doing or how we were doing in support of our patients with depression and anxiety. And as we started to build a measure and socialize that measure, it became very obvious that our physicians were concerned and frustrated because there wasn't a resource to share with our patients. And therefore, there was a barrier in front of us where physicians didn't want us to measure it anymore until we could actually provide resources, until we could invest in all the psychiatrists needed, which we knew we could not do. Northwestern has 5 regions in the area of Chicago and the Chicagoland area, and our academic medical centers in Chicago proper. And so that's where we started to bring on the collaborative care model because we realized it was a great opportunity to provide support to our physicians and patients and meet our physicians' expectations. The hard part about it, as we grew as an organization and tried to figure out how to scale it, was all of the operational nuance needed in order for us to be successful. This takes a lot of grit. It isn't just about a measure and a transaction that gets somebody better. But really, if it wasn't for the measurement, we wouldn't have had the awareness of how poorly we were performing. Because I don't know about any of you, but every physician does everything well. We talked about an A+ earlier. They never do anything off that's wrong. And so we had to, bring some awareness to our clinicians and our practices that we could do better. And then we had to arm them with resources so that our patients could have the outcomes they needed and our primary care physicians could feel supported in delivering that care. And so then we'd had about a few years where we started to scale it in pockets. We have about 90 primary care clinics, 528 primary care physicians, 120 advanced practice providers, and we have about 650,000 unique patients in primary care. And so when we think about scaling, we only had it in pockets where people were interested. And as Northwestern also wanted to accelerate our performance and our success in population health, we realized we had to scale it quickly. And so we went from just downtown proper, a handful of sites, to in our north region in a couple clinics, in our west region in a couple clinics. And then we were able to partner with West Health. And with that partnership, we now have all of our physicians across our organization now has access to behavioral health. How much we refer and deliver, and we have a lot more work to make sure we're getting to all the patients in need, but all of our physicians have access. And it has been instrumental in our journey in redesigning clinical care and primary care, in being more successful in population health, and most importantly, meeting the needs of our patients. And how's it felt for you, Leanne, like coming to us in Northwestern? We're a large academic medical center that's still figuring it out. What was it like partnering with us?
So I think that we felt very lucky to find you when we did. So Northwestern was at a point where you had sort of done a proof of concept, over time in some clinics. And the system itself saw the value in expanding and said, sort of, we have our own intrinsic, motivations. We are going to expand and make sure that we are providing the care our population needs. And yet, as I'm going to ask you more about later, we know that doing that is very hard. So I remember having some early conversations, not with you, but others sort of in the system where they said, why do we need you, West Health? Like, we're just basically turning it on, like turning on the codes or turning on the EHR. And I think we sort of knew from talking to a lot of people that it's much harder than that, right? So we use, codes and technology as levers and enablers, but it takes the hard work, right? And so I think West was very excited to find a group that wanted to do this and was willing to let us come along as part, on the journey.
Love a good partner.
Boy, will you learn a lot by getting in the weeds with folks and really do problem solving constantly.
Yeah.
And so it's been an extensive learning experience, I think. And what we're really excited about is to be able to extract those learnings and create tools and resources to try to sort of flatten that curve for others who want to do this.
Yeah, and to your point about flattening the curve, I don't think, I'm an operator at my heart. I love clinical models of care. I love the work it takes to ensure patients get what they need. But change management and practices and working with physicians is a huge lift. And even we put a measure out there for awareness, for us to start having common language about performance, but the amount of effort it takes for busy physicians to change their workflows, trust people they don't know or see in a plan of care, understand the reimbursement piece and what it's in for them. And we actually had one of the change management pieces we were able to do with the support of West Health and our Department of Psychiatry was helping our primary care physicians understand what wasn't happening. Our primary care physicians very much felt like I did a PHQ, I gave you a Lexapro, you are better, you did not call back. But the reality is, not calling back does not mean you are better. And in our current landscape, we value the transactional parts of our care, but the reality is that it takes a lot of people and a lot of effort and a lot of touches, especially with mental health, for there to be outcomes that help our patients then not only feel better, but then manage the medical problems that they might have related to hypertension or diabetes. And what is unfortunate in the primary care and psychiatry underdogs, who I do love a good underdog, is that the effort that it takes is not something people really understand until you do the work.
That's right, yep. And I think something that we've been talking about sort of all day is levers, enablers and levers. And I think what's unique about this group is that there's so many perspectives and there's so much expertise in this room. And I think what's been so great is that, very similar to our partnership, is where we've been able to align on core and shared sets of values and beliefs around, that we need to change mental health care in this country, and that too many people are suffering for too long. And that there's not one solution.
Correct.
But I look out here and every person has their piece. And so what I hear from the experience at Northwestern was it was sort of the bringing together of, it was a reimbursement code. It was a depression measure that brought to light the need for more care. It was a champion in you and in others. And even then, it's years of hard work to do this.
Yes, and I would say the long game is necessary for any change management, especially in primary care. The wins aren't quick, and when I think about our journey in this work, I am most excited that we kept focused on what's important for our patients and physicians. We didn't give up when it got hard. We are still not giving up and not there yet, but we're working on it. And we listened to our physicians and what they needed. A screening tool is valuable, but the relationship our physicians have is actually more important to the referrals for patient care than one tool. A physician that has been taking care of a patient for 10, 20 years actually understands the dynamics and complexity of their care to know when behavioral health is important. And one tool, one measure is not enough, and we need to arm our primary care physicians and support their expertise in making those referrals so that the reimbursement is following and our patients are getting access to care that they need.
So can I ask you something about your primary, so you've been such a great primary care advocate, and I look at Matt Pressman, primary care, so many primary care advocates, and I remember actually having conversations with some of you when we were just thinking about this idea, and we weren't quite sure what it was. And understandably, the response was like, we can't add more to primary. Like, primary care, needs our support. How are we going to continue to add a new set of measures? Make them accountable for things that they can't always, impact on. And so I'm just wondering, how do you think of not only this NCQA work, but also just collaborative care? How do you sort of win the hearts and minds of your primary care physicians?
So data Doctors are scientists, they want data. And so we actually created so much momentum when we were able to show them that a patient is in the program for about, 6 weeks, or was it 12 weeks?
Yes, clinical remission, 55% in 6 weeks.
And like 6 encounters in that time frame. None of our physicians have access to see a patient 6 times in that short 2 months. It just can't happen. And we were able to win hearts and minds by translating what our patients get access to that will support their outcomes and care, and the overall patient's care when you think of their comorbidities. So data, I can't say enough, is so important. What we want to do, and what we haven't done yet, is be able to help our physicians see those trends through repeated PHQ scores to see what that improvement looks like. We have to, arm our physicians with data on behavioral health, just like we do with diabetes trends, on A1C, hypertension trends. We have to build the EMR to give that information to help inform what care is needed. And then I think a lot of it is about presence and understanding where people are coming from. All of us that get to be leaders and have a voice at the table is a real privilege, but the best privilege is really taking care of patients. And it's our job to be able to translate that to our physicians, but also in these forums. And I think we have to listen to our physicians on what they need, appreciate that what they think they need, like behavioral health is great for depression, the CBHP model is great for depression and anxiety, but our physicians so badly want help with patients that have higher acuity SMI, and we had to bring them back being like, well, we can do this, we can't do that, we can't solve the national crisis. But I think it's about listening, leveraging data, helping people see what the win is for our patients and therefore the clinicians. And our goal in primary care at Northwestern is really all focused on clinical transformation. We can't expect physicians to run hamster wheels anymore. We have to build teams, and CBHP is one of our strategies, this collaborative model in that team-based care, in order to be able to support the patients waiting in line and our physicians that are really tired, working hard every day.
I love that. And when we talk about, so going back to sort of West Health and
I could go on and on about primary care.
Thinking back to what Sia was saying about, affordability and access. And I think, yes, we are in the weeds. We see the things that still need to be fixed. But there are a lot of wins that have already come out of the work we've done together.
Yes.
And so I'm thinking of some of the stats around remission and some around the cost. And I don't know if you want to share any of those.
Oh, for sure. We've been able to touch 2,800 patients since the partnership with West Health. We have at least 2,000 of, I think 1,800 of those patients have been well engaged. 58 to 60% of them are therapeutic. And that is powerful information when it comes to impact to patient outcomes and population health. We wouldn't be able to do any of this without West Health's partnership. We wouldn't be able to take the time to pull back and think of things at scale and know that there's an opportunity to partner with them at the table when it comes to policy. I feel Northwestern's very lucky to have this opportunity, and if it wasn't for that partnership, we'd be slow boating, because it's very hard to be in fee-for-service and value-based care and move at pace to catch up to what's in front of us down the line in primary care. We need to be moving faster than reimbursement allows us to. We need partners that will help us do that, and we need measure sets that can tell the story of what we do for our patients, but in a way that actually helps us move faster in support of them.
That's great, and I just want to add to those great statistics. I mean, there's thousands of people who now, have had a clinical response and are feeling better. Their quality of life is better. All at an average of it was somewhere around $50 a month. Yeah. That you can't get in the door of behavioral health specialists for that amount of money. So I think it's really important that we continue to think about the real impact on the patients.
Agreed. I was thinking about was it Henry that said about you can get a splinter and go to the ICC for $800. When I think about the work collaborative care is, the amount of people involved and the time involved and the phone calls and nobody answers the phone call, and then trying to reach that patient and making sure it's at a time that they can do it with their busy schedules, and talking to a psychiatrist and an internal medicine doctor. I mean, that's well beyond $800 worth of work.
Right. No, it's true. And so we are working with you on the next core measure set, so the measure set we've all been talking about as we're in here. And how are you sort of getting buy-in from your system and your primary care providers? Do you think that's going to be a complicated sell, or you think people see the value in it?
Well, I think anything that is about measurement, that is going to create accountability, is always going to be a little bit hard for us, because physicians, again, every patient's different, every patient's not the same, and so it's about the buy-in from our physicians that help us be successful. But I think what our physicians want, and what we want as an organization, is to have measures that impact the work we do every day to help us reinvest in the work that's needed in the future. So I've heard simple a lot here, and I love that. Simple is key. But I also, we want measures that actually are in helping drive patient care, but also appreciate the patient's part in that care, because it takes a lot of work to engage patients, so they want to make those changes. So I think sometimes we think about some of our measures as a transactional opportunity, but I go back to, there's a lot of work to work with a patient and help them realize that the care is going to help them when they're not aware of it all the time.
Okay, last question for you.
I'm not asking you enough questions.
That's my MO. I'm just going to ask you.
Fine.
So think about other organizations, other systems who are maybe thinking about creating an integrated care program. Clearly this measure set, we're hoping creates a situation where there's more sort of appetite for that. Knowing what you know now, what would you tell those?
Oh, I would say get the data as soon as possible, so that you can socialize and share that as often as possible with physicians and team members. I would say take the time before you launch to listen to the physicians and the care teams to understand where in their workflows they think there's opportunity to add work or not, or what they think would be helpful from the patients that they know and care about every day. Listening, I can't say enough about, making sure we're present at the sites, data from the start, and then to have a real, I guess I would say, communication strategy that helps inform what's happened, what's changed, and where we're going. The work is, I think the long game work, it's really hard to get distracted with what is in front of you today, but investing in programs like this and finding good partners actually takes us months and years to get to the end game, and you have to keep people informed about that so they can see where that North Star is to want to stay invested in the work. We don't want people to be distracted on the next exciting project or model that's out there. So I would say stay focused, get data as soon as possible, and take time to listen to workflows.
Thank you. And I just want to leave everyone here, our final words is that I think we have a real opportunity here to each have shared ownership of this work and to help drive it from our own individual seats. This is not something that sort of the initiative teams from NCQA or West Health can do alone. And I think if we can, not let perfect be the enemy of good, Amen. And if we can, each figure out what our piece is of this, that we have a real opportunity here to really help a lot of people who need better care.
Yeah. You just can't do medical care without health care. We've said that a few times, it's true. Without brain health. Anything else?
Thank you.
All right.